rely back on is think about what tissue is most involved with whatever they're doing. For instance, come slide down for me, Dakari. Alright, so take a look at what I'm going to do here. And let's see if you can just kind of, by process of your previous knowledge, figure out what I'm doing. Alright, so hold your hands like this right here. Okay, so I understand this is the involved side. So would you push against me right here? Any pain? Okay. Now you tell me, what was it I was just doing?
Asymmetric external rotation.
Okay. And then I asked him a question. I said, do you have any pain? Right? So let's kind of work through this. If I ask for pain and I am testing what motion again?
External rotation.
Shoulder external rotation. Then by process of deduction, I go back here 2 muscles. All right? What 2?
Infraspinatus and teres minor.
All right.
Sorry.
Infraspinatus and teres minor. So in my question, it says, what structure is the examiner testing? And then it gives you options. Option 1, let's do it this way, anterior delt. Option 2, infraspinatus. Option 3, rhomboid. Option 4, serratus anterior. What do you answer? Infraspinatus, right? Now, do you see kind of, that's a lot of how they do it. Like they want to know, can the PTA look and see and go, okay, that's what they're testing, and go forward. That's just the whole process right there. That's as simple as it gets. Now, for that, specifically, it's called the infraspinatus test, right? You're going to see that here in a minute. But before we do, Monica, would you tell me what's first on that list right there behind us? We start at the shoulder. Okay, there's some dislocation tests. So go ahead and lay back for me here. Now, shoulder dislocation test, right? Okay, so what it's looking at is, do they kind of have a little bit of apprehension? And the test described on the next page, you can turn over and you can see these. It has an anterior dislocation test and a posterior dislocation test. Anterior dislocations very commonly occur because of external rotation, and the humerus just rolls right out. And so what we do is we take that person and we externally rotate. And a lot of times, if they have an instability, what they'll do is they'll start bowing up like this right here. And what they're doing is they're trying to prevent any more external rotation. And you can look at their face. In fact, that's what the book says, is it gives a grimace. And they're like, no. And if you did that to me with my left shoulder, I would give you a positive apprehension or dislocation test, right? And so as I'm doing that, and then I can take and relocate, and that's another name for the test, is the relocate test, is I can take them into external rotation and then apply a compression over the humeral head, and then immediately they're like, okay, I'm good. Because I feel like this is not going to end bad, right? Posterior dislocation test is from internal rotation. And the same thing, internal rotate, and they don't bow up, they come up, right? And that's from the torque, from the risk that they feel is coming as a dislocation. How are those?
So we have to know the names of them too? Is that what you're saying?
Yes.
Okay. And those are just called that anterior dislocation and posterior?
It's a dislocation test. Yeah, you're kind of at a disadvantage because you're not looking at your book. Somebody tell him what they're called.
Oh.
I know someone will have a weird one.
There we go. Good.
They do have weird names. All right, so go ahead and sit up for me, Dakari. All right, next we're going to go to a very specific tissue. In Therex 2, we're going to talk about this one. Bill probably talked a little bit about it. It's called biceps tendonitis. Now, okay, we hit this on Tuesday just a little bit when we discussed a ligament that crosses the proximal humerus, known as the transverse humeral ligament. Remember, and it was kind of really like, I mean, I saw eyes getting kind of wide, like, I don't know that ligament, right? I mean, it was just kind of like, ugh. Okay, so the biceps has two proximal origins. If you don't know, let me tell you. One is the coracoid, the other is the anterior rim of the glenoid, right? So take that, put that in your mind's eye, kind of like saturate on that for a minute, and you're like, okay, they unite, and then they run sequentially down the humerus through an area of two bony prominences known as the interbicipital groove, right? All that's pretty good for us. We're like, yeah, I got it. And then a ligament binds that down. Well, sometimes there's some irritation in that area, right? So we're not going to get into whys here, but when it happens, a condition known as biceps tendonitis happens. A lot of times people think, oh, biceps tendon, that must be here. Biceps tendonitis is in the shoulder. And they have an anterior shoulder pain. So there's two big tests that we identify there. The first one is Speed's test. And what we do is we supinate here. And a lot of these special tests are strength testing. So hold me tight right there. Hold me tight, 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 tight. Now, another component of this is I put my my fingers right here, and I'm feeling for that right there. Okay? And then there's another version that causes, or that they will pronate here and do the same test, and if you have pain on both sides, that's the positive. Another test that they use is called Jurgensen's test. The Jurgensen's test, and I always remember it, the Y that starts Jurgensen's, and I kind of think about that being the interbicipital groove, and that's what helps me remember that it's a biceps tendon test. I know it sounds kind of goofy, but that's just what I used. This one's a little different in that what you're doing here is you take that patient, and I've actually seen it perform both ways. And so I'm going to actually ask you what your book says on this one. I've seen it performed eccentrically right here, but I've also seen it performed concentrically. Does the book say flex and supinate concentrically under Jurgensen's?
It says 90 degrees of elbow flexion and forearm pronated.
Uh-huh.
That's all it says.
Yeah.
This is actively supinate and laterally rotate against resistance.
And laterally rotate?
Against resistance.
Okay. I've never used lateral rotation. We only used, the way I learned it was we used elbow flexion and supination, and it was resisted. So I would take this patient right here and I would say, all right, I want you to do this right here, and I'm going to resist. You go ahead, right? And then I would feel for that. And then also there was another component to that. They would actually shoulder flex at the same time. So it would be that motion. Okay, go ahead. And I would feel for the biceps tendon to either kind of pop out or just have pain. And that would give me a positive test. What's our next group of tests?
Drop arm test.
Okay, so on the drop arm test, we're putting them into a position of scaption, and we're saying, can you hold it? And if they have a rotator cuff tear, that will just down, okay? Because this will cause pain when they try to hold it. Is the next a Hawkins kid? Oh, so we've moved to impingement. Oh, sorry. All right, so real quick, kind of follow me with your imagination. The acromion comes over, right? Humerus comes up. Now let's apply some soft tissue. Underneath that acromion is something called the subacromial bursa. Underneath that is the biceps tendon. And then we consider the supraspinatus tendon coming over as well, all kind of just punched into the space that's between the acromion and the humerus. And as they come up like this right here, what we know is that there are two tests that are used to identify impingement. And the first is simply taking that patient and actively flexing that shoulder and seeing if you get any impingement signs. Now, if that word impingement doesn't quite make sense, what we're doing is we're compressing those three soft tissue structures we just named between the acromion and the humerus. So the easiest one is the impingement test here, and then Neer's impingement test, and then Hawkins-Kennedy requires a little bit of internal rotation and cross-body adduction right there. You see that? And both of those are impingement tests that we would use. But think about it this way. If I'm just pushing here, right? I'm closing the space between the acromion and the humerus. I'm going to compress that area, right? That's an impingement test. If you don't quite get the names of them, just go back to what are they testing for? Because that's probably what they're going to hit. It's rare that I've ever been told, in fact, I don't know that I've ever been told that the licensure exam looked at the names of the test. They looked at the structures that were being tested. That's what they really focused on. So that's a good thing for us. But honestly, if you can kind of maintain those names, I would. All right, so Neer's is just a passive flexion compressing in with the acromion. Hawkins-Kennedy is a internal rotation and cross-body adduction. Any pain there? Good. That means you don't have an impingement. How we feeling? Next on that list is infraspinatus. And I showed you that one kind of at the start. So again, that is me here saying push against, push against, push against, push against, push against, right? Then there's the supraspinatus test. Hold me tight. Hold me tight. Oh!
Grab you?
Huh?
What am I doing?
Don't grab me.
Oh, yeah.
Don't grab me. No, I just want you to hold tight. Okay, so it's another isometric exam. All good? Let me ask you this. What the heck is thoracic outlet syndrome?
I know how to test it.
Do you?
Yeah.
Okay.
Bruce test.
Dang!
30 seconds.
You seen
My
that on
hands are
TikTok?
numb.
Yeah, I did.
So did
I saw it on
You
TikTok.
saw what?
We seen that on TikTok. It's a video.
I follow a physical therapist on TikTok.
And you learned Rouge test from TikTok.
Yeah.
Do what you gotta do.
It's not all dancing.
You know what you just did?
Took your job away.
You just made a crap. Now I have to go tell my kids that I don't think they suck for having TikTok.
It's not all dancing.
No.
Well, that's what I'm going to do on my TikTok. Cool. So yeah, Rouge. Well, so do we know what thoracic outlet is? All right. It does have to do with the brachial plexus and how it passes through. Now remember, the brachial plexus, you guys learned it is just the bundle of nerves. But kind of to break some bad news to you, there's some vascularity that passes through with it. It's a neurovascular bundle. And like all of a sudden you're like, what the heck? You mean it's not just C5 through T1? Nope. There's a whole network of arteries that go past with that too. And as they pass through these really tight scalene muscles, if the scalene muscles are too tight, it compresses the nerve and the artery, and therefore it causes a paresthesia, numbness and tingling, either from circulation or just from compression on a nerve in the hand. If it's not there, it could also be that you have a really large first rib. and that's just like some goofy thing about you. And so it can cause a compression on the same neurovascular bundle. One of those two is typically the reason. And then also sometimes the clavicle will have something to do with it. But either way, ruse right here. Everybody put your hands up. Let's do a ruse. Come on. Oh, come on. Get your elbows high, baby. 40. I'll look at Stephanie and she's down here.
I feel like I'm all the way up here.
That's called proprioception. And hang on, here's Tara. Yeah, it's got to be a big open and close, right? And what happens is, if you have that compression, either at the scalenes or at the first rib, your hands are going to go numb, right? Two more tests that have been noted here are Adson's and Apley's. I'm sorry, Adson's and Allen's. Adson's maneuver, this one kind of looks a little unique too. So what I do is I take and I get the radial pulse. Go ahead and let that arm come down. And then what I'll do is I'll say, okay, I want you to turn and look at me. Lean your head back. And what I'm looking for there is, again, guess what? The scalenes to compress even more, because now they're active and they're a little taut. Or we just close that space anyways, right? The Allen test, and this is kind of really bad for you because there's an Allen test for this one and there's an Allen test at the wrist. So Allen must have been a vascular surgeon, is all I know, right? So Allen's test is here. I find that radial pulse, and if I get in your business here, I'm sorry. And then I take and I externally rotate, and then I tell my patient to left side bend, and now extend your head. And if that pulse goes away, guess what? I got tight scalenes, or I just ran that sucker right up against that first nerve, or first rib.
Is mine still there?
It's still there. That means you don't have thoracic outlet either.
All right.
Now, I will say, when I went through school, this test was often not validated very well. And then they started actually doing studies on it, and they found that it's like got a mid 70% specificity and a mid 70% sensitivity. And the difference, so you know, and you're going to hear this a lot when you get out of school and you start doing CEUs, sensitivity tells us that the patient for sure has it. Specificity, I'm sorry, I said that wrong. Specificity tells us the patient has it. Sensitivity tells us that the patients do not have it, right? And so they look at both sides and they do, you know, a myriad of randomized controlled trials to get that pinned down. So you'll hear those terms. All right. So let's do this. 5 minutes. Try them out. Just those few.